It is my pleasure to introduce you to today's speaker, Dr. Brett Shannon. Brett is currently an assistant professor at the University of Illinois Chicago School of Public Health in Chicago, Illinois, and an adjunct senior lecturer at the University of New South Wales and School of Public Health in Australia. He has accepted a Canadian Research Chair position in Indigenous Health at the University of Ottawa that commences in September of 2026. He is an Indigenous Aboriginal Australian who has worked in occupational health for the past 8 years as a physician and researcher in occupational injury and Indigenous health with professional interests in the fields of occupational medicine, injury prevention, healthcare access, social determinants of health, and in the continued development of measurable health outcomes for First Nations people globally. Today, Brett is going to be presenting his research on community health clinic presentations of migrant and seasonal farm workers, and I will pass it off to you, Brett.
Thanks, Danielle.
Thank you.
Okay, I will leave this like that. We might change it throughout. Thanks for the introduction, Danielle. It's nice to see some familiar faces at UIC. And today we're going to talk about community health clinic presentations of migrant and seasonal farm workers um, and their families in Illinois. So we got a surveillance research project that got data from 2017 to 2024 for this project. And this work was done with Dana Madigan, who's here today. So today I'm going to talk about this surveillance project, give a bit of background, a bit of context to this data and to migrant and seasonal farm workers, both in Illinois and in the United States. Talk about the methods of the surveillance program, some of our early research findings. And because this is a new project, I thought it would be useful to share a similar example of a surveillance project we did in Australia that's got a decade long of data now, and some of the follow-on steps we did once we started the surveillance project, and then the next steps of this project and some of our future considerations based on these early findings. Danielle kind of introduced me, but I just wanted to share this background just because of the example I'm giving at the end about our surveillance program in Australia. So like Danielle said, I worked as a physician and a researcher in Australia until the pandemic when I came to UIC for my PhD. And since I was 18, from the time I moved to the US, I really worked in community health services for Indigenous people. So I worked in various roles and did a research program around barriers and enablers to screening in community health services, in Indigenous community health services in Australia. And we set up a surveillance program based on that research project that had some similar contextual things and similar findings. So I thought it would be useful to talk about that as well. And that's all I just wanted to share about background, really. And just briefly, some background about this workforce. I think we all know, particularly the people that are here today, farm workers are a very high-risk group. They're exposed to many occupational hazards that may present as many different injuries and illnesses, both in primary healthcare and tertiary care. And agriculture is consistently one of the high-risk sectors, both in Illinois and the United States, as well as overseas. And what we know from the data we have is that hired migrant and seasonal farm workers have been shown to be one of the higher risk groups in that workforce, consistently higher risk of injury and illness than other farm workers. And despite knowing that, we do have a lot of data systems we use generally in occupational health. We have a lot of state-based systems we use in our department that are not as helpful with this workforce. This workforce is very difficult to find information on and to be able to get useful information that we can develop policy and prevention efforts with. So to give an example, in other contexts, we use police crash reports, workers' compensation data, hospital data in various situations, and poison center data. And if we look at them from a farm worker, particularly a migrant and seasonal farm worker context, we don't really get a lot of information from these systems. We can get agricultural vehicle crash reports from police crash data, but this is not going to give us further information about occupation and industry. Potentially, we can get workers' compensation data that will give us some quantitative points around industry and occupation. It'll give us some qualitative data around the context of an injury or illness as well, that may be useful for this workforce. We use hospital data in various situations, but again, hospital data doesn't give us occupation and industry, so we can't use it a lot of the time in this context if we're specifically focusing on seasonal and migrant farm workers. And then we have poison center data where we can look at pesticide cases as well, but we do not get further information typically around industry and occupation and if they're a seasonal or migrant farm worker. So most of these systems we use in other contexts mightn't be as useful in this situation. But also, if we look at those systems collectively, most of those systems are really looking at the pointy end of the triangle, the severe cases that are going to present to tertiary facilities, present to hospital, or start a workers' compensation claim. And we also know that many of these cases, particularly for migrant and seasonal farm workers, do not start a claim process. They're going to be missing from the workers' compensation process entirely. And I just wanted to say as well, in terms of those data systems, we're really missing the less severe cases altogether. We're missing a lot of the chronic conditions that may come up related to work. We're missing anything around overall well-being in this workforce. And we're also missing the positive stories around health interventions or outreach programs that may be providing real benefits in a local context that we could extrapolate to be statewide. So there's a lot of gaps in those state-based systems. As well as those state-based systems, we have national data on migration and migrant and seasonal farm workers that we can use. And just before we go to the US context, I think it's really important just to reiterate that global migration is increasing. We have about 244. I'm just going to close this so it's just putting the spotlight on you, Danielle. But maybe I'll just bring it down here. We have about 244 million people living outside their country of origin, which is about 3.3% of the world's population. And it's estimated a half of these are immigrant workers. So there's another half that are not workers. They might be family of immigrant workers, or they might just be immigrating for another reason. And it's really important to reiterate the benefits of international migration. So migration is really, really important for social and economic development. It's really important for skill development. It's really important for Illinois as a whole. And I think it's an inherent challenging area in occupational health. I know it was a challenging area for me in Australia before I transitioned to the US. We had a large migrant farm worker workforce that was flown in from Fiji and other countries. And we had to deal with various different conditions and situations. And it's a very difficult challenge here in Illinois as well. But it's a really, really important area that we focus on taking care of migrant and seasonal farm workers. I'm just going to, so we can see this slide, I'm just going to get rid of this. This article was in Public Health, and I think it's a really important article just to briefly mention. So they highlight in this article the consequences of various temporally related events and different treatments at various stages along the migrant pathway and the health issues that might manifest before the migration even begins, during travel of the migrant, and then once they reach their destination. And I think it's really useful to think about this when we're talking about community health data, about some of the issues that might manifest in the community health center they might need to think about with these migrant workers and their families. So if we think about even before the migration process, you need to think about what is the disease profile of the workers and their families that might be coming to Illinois. What are the specific conditions they may have? And then during travel, there's a lot of things we don't think about, medications and other things that are not taken during the travel that may be required on destination. They might lead to other health conditions as well. And then once you reach your destination, there's cultural and language barriers to think about. There's potential access barriers to services. And then there's legal and discriminatory concerns that may cause other conditions as well. So we have very limited data on all these issues for families of migrant farm workers is kind of the point I wanted to make with this slide. And it also makes you think about all the issues that may stem in these families that may make them reach out to community health services for supports. So it's a really good article and worth reading. And the link is down the bottom of this slide. Let's see if this. And just a bit of background about hired migrant and seasonal farm workers from our national data. We know we have about 2.5 million in the United States, 80% in crops, 20% in livestock, about a quarter identify as female. The mean age is in the 40s, majority are foreign born and Spanish speaking, and about 50% lack the legal status or work authorization. We also know about 80% are settled in the United States, about 10% travel a long distance for work, 5 to 10% follow the crop from south to north, and 3 to 10% cross the border for work. Going back to families of migrant and seasonal farm workers, I thought this was some interesting data to share. It's quite old data. So this is NORS data from 1993 to 1995, and it gives some information on children in migrant farm worker families. It'd be nice to look at some more recent data, but this data here from NORS, it breaks down into children where both parents are foreign born and then children who have one foreign born parent. And you can just see some of the issues that might stem, or some interesting facts I thought anyway, were uh, looking at the children's families that migrate each year. So they migrate every year, was nearly a third in both groups. Children who are behind a grade level at school was about a 6 or 15% for both if both parents were foreign born, and just over 10% if one parent was foreign born. And you can just see the economic indicators where median family income is very low. Majority of families are below the poverty line in both groups. And most or 2/3 of both groups were receiving federal services. And also interesting just thinking about like non-family present in the household and housing conditions. Nearly a third of both groups had other people in the household. So just some interesting facts. It'd be nice to get some more data, and it'd be nice to look at some of these variables for Illinois specifically to understand the children in these migrant family workforce as well. I'll bring this back up so you can see me. So that was a bit of background information, just briefly to give a bit of context about this project. And this project is our new surveillance program from RP2. And it was really about establishing partnerships with outpatient health services and community health services in Illinois to look at some of this clinic data from these migrant health centers and understand what are the needs and what are the issues of migrant and seasonal farm workers and their families in particular. And I just wanted to reiterate before we go into the methods of the project that, much like a lot of my Indigenous health projects back home, a lot of the work in these surveillance programs takes a long time to establish up front. It took about a year to establish the DUA, and the data transfer process is ongoing and lots of quality assurance checks. And I think it's really important to just take a step back and take your time with this part when you set up a surveillance program. If you don't do this right at the initial phase in the first year or two, it will not end well, and it won't make the rest of the surveillance program seamless. So this did take a long time, but hopefully this is set up well, and now we can continue this program, continue working with these health centers for many, many years. So once we established the DUAs, we looked at the clinic data and we identified patient visits for agricultural workers and their family members who attended these federally qualified health centers. The total for Illinois was 6 health and dental clinics and multiple outreach sites across mainly northern and central Illinois. Our criteria were we identified farm workers 18 years and older and compared clinic data to presentations from farm workers' family members. We used data from 2017 to 2024, and we got a number of demographic variables and a number of clinical variables from the clinic data to assess and compare migrant, seasonal, and family members. Danielle, I might just hide this and put you up front just so people can read this as well. So just wanted to note as well, we use the HRSA migratory and seasonal farm worker definitions, as do the clinics. And it's just nice to point these out that Migratory agricultural farm workers, they're usually hired laborers who are paid piecework or daily wages. And these include patients who have had such work as their principal employment within 24 months of their last visit during the calendar year, as well as their family members who have also used the centre. Um, so the important difference in definition between migratory and seasonal is that migratory workers leave their community and they also establish a home in the new place, whereas seasonal farm workers work on a seasonal basis, i.e. picking or working in agricultural for a limited months of a season, and they do not establish a temporary home for the purposes of that employment. So that's the difference between the two groups. And now I just want to get into some of the results quickly. So there are our definitions. Our three groups were migratory farm workers, seasonal farm workers, and family members of these groups. So like I said, we had a number of demographic and clinical variables to look at with this data to start looking at differences between these three groups. So this is 8 years of data. So you can see we had about 6,500 family members. We had nearly 9,000 seasonal farm workers and 6,500 nearly migratory farm workers. So here we're just looking at gender of farm workers and their families. Stretch this out now. And you can see family members is green, seasonal is yellow, migratory is blue. And you can see already there's differences in the three groups. If we look at family members, over half identify as female, which includes spouses and children. And there was a slight difference in seasonal and migratory, where seasonal had more female, nearly a third female, whereas migratory farm workers was around 25%, which is kind of in keeping with that national data. I think the national data said about 20%. So we actually have a few more female in Illinois than national data. If we break down by age, the three groups, comparing family members, if we look at family members to start with, you can see children makes up a lot of the group. So over a quarter were aged 10 to 17 years, and then followed by 18 to 24 years, and then it kind of plateaus and goes down, but we still have a large proportion, I would say, between 25 to 54 years, and then even some elderly family members as well. And family members, you can see, was the only group that had some missing in the age variable. Comparing seasonal and migratory farm workers by age, you can see migratory farm workers, the largest proportion was age 25 to 34. So it's a little bit younger than seasonal farm workers. And then seasonal farm workers, the largest group was 45 to 54, and closely followed by 35 to 44. And if we compare that to the national data we just talked about earlier, which sort of had a mean age of in their 40s, it looks like our migratory farm worker workforce is a little bit younger than the national data, and then the seasonal is probably quite similar mean age to the national data. I think that's all I wanted to say for that. Then the demographic data was not complete for race, ethnicity, and some other variables, so we didn't include them in the preliminary analysis. If we now look at some of the clinic data, so we have for clinic data, we have ICD codes, reason for visit codes, medications, and that was kind of it at the moment. So each visit has an ICD code attached to it and a reason for visit attached to it. So we started breaking these down. I'm just going to close this for a second as well so you can read this. We started breaking these ICD codes for visits down by the three groups. So you can see this is not by patient, but by visit. So we had about just over 60,000 migratory farm worker visits. We had 260,000 seasonal farm worker visits, and we had nearly 180,000 family member visits to the clinic. And straight away, you can see there's big differences in what the groups are coming into the clinic for. If we look at family members in green again first, you can see dental exam is the largest group. So nearly 20% or about 17, 18% of visits is for dental exams, which is predominantly in children. And this was closely followed by educational specialist visits, which is one of the Z codes, I believe, that's specific. And then it was again followed by Z codes. So Z codes, for those that don't use ICD codes, can include anything from Z codes for education, Z codes for domestic and family issues, Z codes for employment issues, schooling issues. So it's all your sort of issues related to social determinants, as well as some special Z codes. So that was family members, the big groups. But you can also see family members are coming in for a large proportion have metabolic conditions, a large proportion have circulatory conditions, diabetes, nutritional deficiencies. So you can start gleaning what are the clinical issues that families are coming in for, that we can potentially work with clinics and provide prevention programs and provide wraparound support for. If we move on from families and look at migratory and seasonal farm worker visits for a minute, you can see they're quite different as well. If we start with migratory farm workers, which is the blue, you can see a lot coming in for case management visits, a lot coming in for educational visits, followed by those Z codes and social determinant visits. A lot less for dental exams, a lot for migratory, just coming in for a nurse's visit. And then if we look at seasonal farm workers, you can see what was different for that group really was a larger proportion had metabolic disorders they were coming in for. It had the largest proportion of diabetes, of circulatory disorders, of nutritional deficiencies, but they were also coming in a lot for these Z codes. So looking at this data holistically, like my first thoughts were, we really need to break down and talk to the staff about what these case management visits are, what these educational visits are, do a specific breakdown of all the Z codes and figure out what Z codes are actually being used. I think nursing visits can be for a variety of things. It'll be nice to know what these nursing visits are for migratory workers, if they're for screening of something or if they're for something specific. Metabolic conditions in seasonal farm workers, I think the rate of diabetes and other metabolic disorders is an important follow-up area to look more deeply into. And then chronic disease in children. I think I'll go into the children's statistics a bit more in a minute, but some of these figures for what is a predominantly child-aged family members is not concerning, but just wants further review to understand what is the makeup of some of these conditions in the children that are aged sort of 0 to 18. How many have diabetes? How many have some of these chronic diseases? How many have mental health issues? And what can we do to support clinics on that front as well? And on saying that, it's probably a good segue to the next slide. So this is about reason for visit codes for adult family members and child family members of farmers. And we just wanted to look a bit more at separating what exactly is happening with the children and what's happening with adult family members. And you can see they're quite different. I think the child family members, if we start there, a higher proportion are coming in for mental disorders, for respiratory disease, a large proportion for these education visits, and dental exams was 40% of all visits. And then the adult visits, a lot are for education, which we need to look into further. Still a big proportion for dental exams, but nowhere near as much as the child visits. And then a large proportion for sort of your cardiovascular conditions, diabetes. The vitamin D deficiency was interesting, and then sort of thyroid conditions as well. So we can start breaking down by age group even further and start looking into this a bit further for family members. We did an analysis of medications for all three groups. And what was interesting is if you cluster the medications, it really broke down into 5 categories for the top 10 medications. So the 5 categories really were antibiotics, anti-inflammatories or muscle relaxants, cardiovascular medications, antifungals, and sort of supplements such as melatonin, B vitamins, and calcium. Go back to this. And just to note, we could look at payer as well for this data, and over 70% of visits for all three groups were self-pay, which was really interesting as well, followed by Medicaid and commercial. I was also interested in medications specifically for children, family members. So we could start looking at what children are being prescribed. And you can see it's much less. It's only 1,000 medications over 8 years. But you can start looking at Tamiflu is probably as expected, is about 20% nearly. Amoxicillin and antibiotics are quite high. Some interesting ones, but was aripiprazole, so an antipsychotic, which we'd want to sort of talk to staff more and say, is this an issue, or is it just a couple of children that were coming in for 8 years, which makes it look like it is higher than it actually is. And then we saw metabolic conditions was quite high in family members. So in children, we had a lot of fibrosol, so dyslipidemia conditions, which is kind of interesting as well to look further into. And then antidepressants was in the top 9 as well. So it gives you a bit more information to talk to staff about and start thinking about what we could further look into potentially for children, family members as well. That was the initial data analysis. We have limited variables we can use from this data, but I think it's really, really useful still. It's really useful from a physician's point of view to start identifying diseases and risk factors in different groups. We can identify deficiencies and susceptibilities. I think injury data and exposures, you can start gleaning what injuries are happening in each group. Mental health and psychosocial risk, we can start looking at who's actually coming in for mental health medications and who's coming in with mental health conditions. I think in the children, we don't have a lot of information of children in migrant and seasonal farm workers' families. What are some of the neurodevelopmental, emotional, and behavioral conditions? And I think this would be a nice way to sort of talk about how we could screen for some of those conditions and how we could support children and these families who are experiencing some of these conditions. And then medications, vaccines is obviously a big concern if vaccine schedules are behind, and how we could set up screening programs with some of this data for vaccines. Medication data is very useful for identifying predominant diseases and conditions that we could support, and then special need groups as well, certain disabilities and things like that. So despite having limited variables at the moment, I think there's so much information you can glean from this data, and it can be really, really useful depending on how we use it. And this is really just following on what I just said, that data helps us identify common health issues. With this surveillance data, we can also detect emerging trends. We can look at local data and start splitting the data up by local areas and looking at targeted prevention programs in certain groups. We can monitor and support child and maternal health among this farm worker population, which I think is a really, really important aspect of this work. And then intervention evaluation for research programs on some of those social determinants of health. Given how many of those codes were around social determinants of health, people coming into the clinic for, I think that would be really, really useful as well. So that's the initial data and where we're at right now. That's the initial analysis we did in the last couple of months. And I just wanted to share this example from Australia of doing a similar analysis and then extrapolating it into policy and program changes over a decade and what we found and what was useful. So like Danielle mentioned, I'm from Australia, and I worked in these Indigenous community health clinics in Australia for over a decade. These are some of our community health centre clinics. So this is the clinic from the island where my family's from. And this is the clinic on the Gold Coast. So my region is sort of this region of Australia here. And so back in 2012, I did an analysis looking at barriers and enablers to health assessments in these clinics, and talked to staff and figured out how can we support staff to get these health assessments and screening programs undertaken, but not be a burden on staff. And we sort of built it around four key principles. One was around intentional community engagement in all our planning and service delivery. One was about what workforce capability do we need to grow these screening programs. Third was everything needs to be evidence-based. And fourth, which is probably really interesting to think about for Illinois, is we set up strong clinical governance systems and processes for all our clinics. We worked with the clinic directors, all of our administration staff around all our data systems. And we developed a model of care based on that clinical governance system, which incorporated sort of patient-centered empowerment in the model, but it was all around business models to ensure we had adequate resourcing based on what we wanted to do and based on what we were seeing in the clinic. And now we have over 100 clinical indicators using this primary healthcare data in our Indigenous clinics. Everything from weekly data that is fed back to the clinicians about what they're seeing, what proportion of all of their clients data was correct, what data wasn't complete, what's trending in terms of disease stratification, what diseases we're seeing in different seasons of the year. So it's a really rigorous system that's just completely streamlined now. And it just started with a surveillance program similar to this. So so this picture here, I have this jersey. So we set up a program called Deadly Choices, and we actually incentivized certain parts of clinical care. So I think it's important to reiterate with this group as well, in Indigenous clinics, there's a mindset that a lot of people are scared to go to a community health center. They might think their data is being stolen. They might be scared that something's going to happen to them. And we understood that, and we worked with community sporting organizations, community centers, community teams. And we also incentivized and made community days out of coming into the clinic. And one of our best incentives was designing these jerseys. And so we set up a screening program with health checks. And if you came and got a health check on one of our community days, you got one of these jerseys. We aligned it with the community football teams and things like that. And it just took off, and it made people feel welcomed. It really made the clinic part of the community and kind of got everything outside of the four walls of the clinic room as well. So you would do screening as well on community days in football fields and things like that. And it was a huge, huge success. And the other point of doing this was once we ran the business models, we figured out what the black holes were for our clinic. So dental was the biggest black hole of our Indigenous community health clinics. We got no funding for it, and it was just taking all of our money. So we started figuring out what we could leverage in terms of screening programs and both state-based federal funding programs, philanthropy, and then rejigging it so that it would cover whatever we had to spend money on, because obviously dental is so important, and it's clearly so important for these farm workers' families. But we didn't want to lose it, so we had to leverage other parts of the system. So that's a quick summary. And to do that leveraging, we actually combined everything from not just primary health care, but dental, specialist services, childhood services. We have a school. We set up a program called Birthing in Our Communities, focused on maternal and child health. Again, there's that scare factor about coming to the clinic if you're pregnant. And we did a lot of birthing in our community around engagement outside of the clinic. We set up home care services. So it's really not just thinking about primary health care and physicians, but it's thinking about this holistically and how can we support each other and some of this data. How can we make sure referral processes are really streamlined so that primary healthcare physicians are not having to focus on some of the issues that may be better suited for allied health or for family planning or family and wellbeing services. And this is one of the posters for that program I told you about, where we incorporated the jerseys into the screening program to get people through the door. And just to show you what the success was, I'm just going to get rid of this for a second. So that screening program, like I said, was a huge success. Within our clinics in that Southeast Queensland area, we increased from 8,000 to 35,000 over sort of 9 years, 10 years. We increased our health assessments from 2,500 to 23,000 per year. And then we increased our chronic disease care plans by 500%. And I guess the other important point to make about these screening programs and making people feel inclusive and invited into the clinic is it was not just about making money and setting up a business model, but we actually had a 25% hit rate for new chronic disease when you're actually just focused on screening. So we identified a lot of hypertension. We identified a lot of metabolic disease that kind of would have been missed if we're just focusing on the presenting complaint. So if people came in for an acute issue, you would also streamline the process that they could come back to do a health check and do some holistic planning. So in saying that, I know it's probably a mouthful, but I thought it was really interesting just to compare and contrast and think about how we could actually use this data and work with these clinics similarly in Illinois. And obviously, the first thing that comes to mind is things like heat-related illness, chronic disease screening, metabolic disease, and mental health and well-being. But you could go a number of issues, and I would really focus on what the clinic wants to prioritize and what their needs are, not what we're saying essentially. But these are just some of the things to discuss today. So in terms of heat-related illness, thinking how we could work with community health services on some of these issues. Obviously, this is a big issue in Illinois, and it's going to be a bigger issue in the next 50 years. I'm just going to close this again. With projected increases in daily temperature in Illinois by 4 to 9 Fahrenheit on low end estimates to 8 to 14 degrees Fahrenheit on high end estimates from our university's data. This is going to be a big issue, and it's going to be an increasing issue in Illinois. And just thinking about risk factors for heat-related illness and how we could stratify and screen and work with the clinic on this data. We know some of the risk factors for heat-related illness are an individual's age, acclimatization to their work, obesity and metabolic conditions, their consumption of water and caffeine and alcohol, their diets, other conditions such as pregnancy, diabetes, and dermatological disorders, dehydration causes, and certain medications. We could use this data and look at certain medications and sort of see how many are at certain risk. We know that certain medications put people more at high risk of heat-related death. One study in the US specifically found that 29% of heat-related deaths took medications associated with heat-related illness, and these are on this slide. And we know that a lot of farm workers, based on this data, are on diabetes medications. We know that a certain proportion are on antidepressants and probably antiplatelet medications as well. So we can start using this data and sort of stratifying and looking at, is the risk profile higher in certain areas? Obviously, seasonal farm workers, it looked like much higher proportions of diabetes and metabolic conditions that may put them at more risk, particularly in Illinois. And just to further reiterate that, it made me think about this Texas heat stress awareness program they set up in their clinics, where they started stratifying based on those risk factors. And if workers had no risk factors, they just got a prevention education card. They just got prevention education from the physician. If they had one risk factor, they got a nurse review and they got a quick card education card. If they had two risk factors, they got an individual medical program. And then if they had any unstable health conditions that would warrant them at severe risk, they were put on suitable duties. Obviously, this is not what we would do necessarily, but it just makes you think about how we could highlight prevention within the clinic setting, and even the education and quick cards and education posters and things like that, I think are so important coming from working in a clinic and just talking to patients day in, day out in some of these clinics. We have a lot of remaining challenges in saying that. There's going to be issues with consistency in reporting and best practices. This is going to vary by location and by clinic and by provider. Identifying hired farm workers, particularly by type. Obviously, one of the big things we need to talk to these clinics about is if that definition changes, if people are flagged as being a hired migrant farm worker or a seasonal farm worker, if that's ever checked again. Getting data that can really inform outreach and intervention at a local level is going to be really important for us. We don't want to just create data and sit on it for the sake of creating data. I think it's got to really be useful at a local level. Defining what a case is and what our numerator is for actually how many farm workers do we actually have. and how many injuries and illnesses in those ag workers are we seeing. So our denominator and numerator is going to be very tricky going forward about sort of determining some of those rates and then whether those match. In terms of next steps, maybe this is something that we could discuss as a group here now. I think we're right on time at 12:44, but I think outreach data to confirm some of this data would be really useful. So farm worker feedback, identifying barriers that are not captured in the data. Like I said, in Indigenous clinics, we had really fear of going to clinic. We had transportation issues, and we had other barriers, but this might be language barriers, work schedule barriers to actually attending clinics. We need to bolster some of this data with community-based participatory research, get some qualitative data from our community narratives, confirm, are these actually the health needs that you're seeing? Is the data correct, or do you think it's completely incorrect? And then use both the qualitative and the quantitative data to prioritize some of those prevention areas. And then I think just informing our research agenda for social determinants and occupational health and child and maternal health with the family data is going to be really useful. I think there's a lot of work to do. We're just getting started here, and I think it's really exciting times. And I think it's been a really, really fun reflection doing this talk today. And hopefully we can have some good chat about it now quickly for 15 minutes, because I think that is it. And I just want to acknowledge our partners, acknowledge the center, and really thank Dana Madigan for bringing me on for this. And it's been a really great project. So that's all I had to say. I know it was a lot very quickly, but happy to answer any questions now.
Thank you so much, Brett. That was an amazing presentation. Does anybody have any questions that they would like to ask with the last 15 minutes? Feel free to drop them in the chat as well, and I can read them out loud.
I have a lot of questions. This is such a great talk. Thank you so much for this very just interesting presentation, very well delivered, of course, as usual. And wow, thank you for this. A big question that I have, and I don't know if you could really answer it off the cuff, but if we were going to get input from the two clinic systems that provided the data to us, both from the healthcare providers and from the administrators, what would you want to hear about from them? Like what are gaps in your understanding that they could fill in if we ask them?
Good question, Linda. When I did this in the Indigenous clinics, I sat in on the clinic, every clinic for multiple days, and I watched what everyone did and did like a task analysis and looked at every process from when the patient comes through the door to who they see, how long they see for, what happens with the data, who inputs the data, who checks it, and kind of systematically did that for each clinic. And then after that, got everyone in the clinic in one room and did a big focus group, essentially about our findings from data and my findings from just sitting in the clinic and doing that analysis of, and then trying to tease out the gaps or the issues between staff on a regular day. And then literally just had a focus group for probably an hour and a half, 2 hours in each clinic, and just let them relay what they would want to see, what their issues were right now, if they disagreed with any of the data that I'd provided, and kind of had someone taking notes and then did a report back to the clinic about suggestions and based on all their feedback. And the biggest feedback, and it's kind of interesting, your question, was we completely changed the model where, I don't know how you would do it here, but we kind of did the same thing that they did in Alaska, where they set up a pod model. So everything was, the gap was the physician, the issue was the physician, we set up a pod model where you have 4 staff in a team, an admin person, a health worker, a nurse, and a doctor. And we took a lot of the stuff that the doctor was doing and put that on the nurse and the health worker and then streamline those processes. And everyone just loved it because the nurse and the health worker and all the other staff had more ownership and felt sort of more appreciated. And then the doctor wasn't burdened doing certain things. But that's where I started, was the focus groups and sitting in the clinics. And then it changed our model of how we delivered services, but also changed how we build and the business sort of models we set up. And then on the back end, we just started looking for funding in all different places. And obviously, I don't understand the funding models as well here as I did in Australia. And that's why we incentivize certain things in Australia that we knew we had funding for. And then we just kind of filled the gaps with that, if that makes sense. But uh, what do you think of that? Is that feasible, or is that
What do I think? I
yeah,
think that is feasible. I have more basic preliminary questions,
yeah,
that I think that I feel like I would want to understand about this data. Um, some of the stuff that you said, like who's filling it out and sort of how does this all work? But I was also thinking about like I'm not sure what the meaning of all of it is. Like the first slide that you showed, or one of the first slides of the results showing the reasons for the visits. Like it looks like apples and oranges, like some have there's some specific diseases, and then there are, other kinds of reasons. So I would want to hear from them, like how do they assign that category
yeah,
there? Because I would have broken it down differently than you did. So but I like that you showed it in such a raw way. So that, that's kind of one thing, and then just get their reaction to,
yeah,
like, is what you showed in the data, what they expect. Is this what they think they're doing and seeing in their clinic? And then, of course, how could we be more helpful to them? Like, what
mm,
kind of analyses could we do for them that would be, helpful to them? Because they're struggling also. This is
yeah,
very small proportion. They're a full-blown FQHC system. This is a very small proportion of their patient population, and they're struggling with funding in 2026. How can we be helpful to them? But
yeah,
anyway, I
yeah.
had a lot of questions, but this is just such a nice, first look at this. It's really great.
Yeah, you know what, the most useful thing for me was sitting with the receptionist for like a half a day. They know everyone, they talk to everyone, they know every system of
Uh-huh.
the clinic. I
Uh-huh.
found it way more useful than talking to the physicians or
Uh-huh.
the
Interesting.
and then like you said, it would be interesting to know if people are coding things differently, what training they get, what I want to know what those Z codes are, like why, what's an edge, what are all the education visits being flagged as, and that's what I would be asking the clinicians.
Yeah.
And then looking at their data system, I'm sure there's more that we could extract and use to support them, if we could look at the back end of it. Yeah.
Interesting.
But yeah, keen to chat. We could have like a big brainstorm one day potentially,
Yeah, that'd be nice.
because yeah, I'm around for one more month. Yeah.
Are there other questions, you guys?
Hi, Brett. It's Kathleen Kennedy. How are you?
Yeah, I'm good, Kathleen. How are you?
Great. Wonderful presentation. So this is a little more about the logistics in the front end. I think there was a slide at the beginning. I talked about a year to get the DUAs up and running. And just sort of if you can speak to that process, how you maybe identified the clinics, how you got the
Mm.
buy-in, just sort of maybe the nuts and bolts of how those formal relationships took place.
Yeah, thanks, Kathleen. I came onto this project a bit later due to my situation. Do you want to take this question, Dana? Is that okay?
Sure, and Linda would probably
Uh,
be good to answer it as well, because for the at least with one of the clinics, there was support written into the grant proposal. So that was kind of thought out and established from the beginning, and Linda had a good working relationship with them. The DUA process just takes a long time across the board. I just sat in a meeting with another of the surveillance programs at a different NIOSH Ag Center, and they were talking about how this DUA process is like just crippling them because they cover multiple states, and like we're really lucky in that our DUA covers multiple years and is kind of ongoing, so we can continue to do this. But it sounded like they were doing things very one-off. So I would recommend, if you think this is going to be a long-term partnership, try to write your DUAs with that expectation. One thing we always tell our partners is like, just because we have a DUA doesn't mean you have to give me the data, right? So like, if they're worried about capacity or long term or things like that, this is more just to kind of cover the processes, not a guarantee or a contract that they're going to provide it. And that has been helpful in some other settings. The second clinic that we worked with, it was a much simpler process. So I think a lot of this just has to do with kind of like legal and oversight at UIC and then our partner organizations. And so, yeah, that buy-in. I mean, Linda, maybe you have a better memory because I was on leave for part of this, but I feel like that one was really quick to just kind of, get working.
Yeah, it's sort of paradoxical actually. So as Dana said, we wrote one there. These are two clinic systems that we know see farm workers because they report to a federal repository and they get funding from the federal government because of their census of farm workers. So that's how we found them. They're the only two in the state, I think. And then one system, which had 7 clinics when we started, we've all worked with them in the past, and they helped us conceive the research proposal. So they were really involved with it. They changed electronic health record companies, I think, in the middle of all of it, which was part of the delay in getting data from them because they had to move all their data into a different system, into a different, electronic health record system. And they also had, I think they had an H-1B worker. Who was extracting data and wasn't super experienced with that. So that took a lot of back and forth. So with them, it was more difficult actually, even though they wrote the grant proposal with us and we allocated the funding that they asked for to get the data from them. The other clinic system didn't have all those issues. It's a much smaller system and it was just boom, 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 you know,
I
getting their data.
Yeah, and I was gonna say, I think one of the things that really helped is we, as part of the center, are working with these organizations in different capacities. So I think, for both this project and some other projects that we've had to navigate many DUAs with non-research organizations. I think that like further partnership is really helpful. People are really hesitant about just handing over their data and then not being kind of consulted on the interpretation and analysis of that. And one thing that we try to do, like Brett was saying, is like, we love data. We have this capacity. What can we provide you to make your jobs better, like what kind of metrics would maybe be helpful, or what can we kind of maybe help report out. So I think kind of using using it as not just getting the DUA, but like really that full partnership for outreach, interpretation, engagement with like the impacted or the people who are part of the data sets and things like that is all really important to get that process underway. But I see other questions, so I'm gonna stop. Sorry.
Thank you.
I did see Janelle's comment. That is a great observation, Janelle, and I think Brett said that he'll have a look into it, so maybe we can hear more in a future meeting or in an email soon. Any final questions? It is 1 p.m. We can stay on if anybody else has anything they want to run by Brett. Okay. Thank you so much again, Brett, for your wonderful presentation, and thank you everybody for joining. These slides will be shared out along with the recording of the presentation and then uploaded to our website, and we'll make sure to share that link out. Hope you have a great rest of your day, and thanks again for joining.
Thank you.
Thank you.
Nice to see you, Gerardo.